Good afternoon, good morning, or whatever time you are listening to this. I'm glad to be involved in being able to talk about gynecology for the general surgeon. I'm going to be including some obstetrics as it relates to general surgery as well, especially the surgical evaluation of the obstetrical patient. My name is Mark Dassel. I'm a physician here at the Cleveland Clinic and the director of the Center of Endometriosis and co-director of chronic pelvic pain. And you'll see some of, I'll talk about as well, chronic pelvic pain and endometriosis during this talk. I do have one disclosure. I received research funding from Myovant Sciences for a medical trial, but that's it. The objectives of this talk will be to recognize important topics in OBGYN as they relate to general surgery. We're going to review a little bit of gynecologic related anatomy that you may not have seen in this way since medical school. We're going to describe etiologies of gynecologic related chronic pelvic pain, abnormal uterine bleeding, which are two major topics in our field. We're going to discuss considerations and surgical procedures of pregnant women and recognize some of the do not miss pathologies and discuss gynecologic cancer screening as well. At the end, I want to end up just recognizing some of the intraoperative pathologies that you may see that are gynecologic in origin, and they may have pathologies worthy of referral, and we'll talk about maybe what the best next steps are related to those pathologies. So just as a little overview, again, general gyne anatomy, the perineum, the intra-abdominal anatomy, and also talking about the pelvic exam, abnormal uterine bleeding and fibroids, chronic abdominal and pelvic pain, the workup, and then we'll talk about endometriosis, which is a major contributor to this pathology. We're going to talk about cancers, uterine, cervical, ovarian, and vulvar cancers, and then surgery in the pregnant woman with especially considerations on maternal the maternal changes in pregnancy, imaging considerations, what the anesthesiologist should consider, as well as what operative considerations you may have with the pregnant woman. So caution if watching this in a public place, because this is something you may want to cover your screen. So this is the vulvar anatomy. We should go over this really quickly. So the vulva is generally bounded by the inner aspects of the thigh as well as the mons pubis. Up at the top, the clitoris being at the 12 o'clock position, directly below the urethral opening, and below this, the hymenal ring. The labia minora is the soft epithelial, usually lubricated skin in the more medial aspect of the vaginal vestibule, and this makes up the border of the vaginal vestibule. The labia majora, of course, are the folds of more squamous epithelial skin bilaterally and laterally extending to the mid thigh. The perineal body is what typically we have formally just referred to as the perineum, but the perineum is actually this whole area extending from the anus to the mons pubis, and its underlying structures to the level of the urogenital diaphragm. So more appropriately, the space between the posterior fourchette, the lowest portion of the vaginal vestibule, to the anus is called the perineal body. Here's an example of a cutaway looking at that perineum. So we're looking at, on the left portion of the slide, the superficial muscular components, including ischiocavernosus, bulbocavernosus, superficial transverse perineae, and these are the structures most commonly injured during childbirth, but also some of these deeper structures can certainly be damaged, including the deep transverse perineal muscles, the external urethral sphincter, and the urethra, especially if there are anterior tears. Looking more deeply, looking at the posterior portion of the anatomy. We can see the deeper muscles here, the pubococcygeus, iliococcygeus muscle, as well as the coccygeus muscle, and this makes up those deeper pelvic floor muscles, and these can commonly be associated. We'll talk about it later with chronic pelvic pain. All these muscles can, but certainly these deep muscles are certainly a part of that pathology. This is another look at those deep muscles. You can see that the levator ani muscles, if you look to your top left, include the puborectalis, pubococcygeus, and iliococcygeus muscles. And this, you can see it does actually extend up to the pubic bone and anchors to the midline raphe, that is the anococcygeal ligament as well as the coccyx. But this shows a little better representation of those deep muscles. Looking now at intra-abdominal anatomy, especially the view we see during laparoscopy. This is a view of the pelvis, looking down from an umbilical 5mm trocar. We're looking at obviously the uterus centrally, the fallopian tubes extending bilaterally from its 6 o'clock position. Just posterior to this, we can see the uteroovarian ligament attaching the uterus, obviously, to the ovary, as it would suggest. The uteroovarian artery travels through this. And then you can see the large white structures of the ovaries in the posterior aspect. Now looking a little more detail, some of these ligaments, again, extending from the uterus. You can see the round ligament extending to the sidewall. This will extend into, to and enter into the internal ring of the inguinal canal, along with the inguinal branch of the ilioinguinal nerve, the genital branch of the genitofemoral nerve, and this is a place where oftentimes we can see neuropathies from surgery in this area, most notably repair of the indirect hernia. You can also see on this, you can see pathology on this, looking at a small fibroid off the posterior aspect of the uterus. And this large ovary is the endometrioma of the ovary, you can see here. Looking at a pelvic exam, how to do a full and proper pelvic exam. I know we've all had this in medical school, so I want to run through this quickly, but I want to add a little bit of additional that may not have been emphasized in medical school and may be helpful, especially in the evaluation of chronic pelvic pain. First of all, of course, a visual external exam, which we discussed the proper anatomy just prior. We also want to look at sensitivity to this area of the vulva, looking for vulvar neuropathies, and the vestibula. The vaginal vestibule, which is all the area medial to the labia minora. And what we'll often see here is one, we can see neuropathies, but also vulvodynia, which is usually, which is an unexplained tenderness, usually related to either sensitivity of the skin, or it can be related to vulvar neuropathies as well, and sometimes a centralized pain syndrome. It's important when looking at this is this patient menopausal, or is this patient not menopausal, etc. The Skene's and Bartholin's glands can also be evaluated. Bartholin's glands tend to be located at the 5 o'clock and 7 o'clock portion of the vaginal vestibule. The Skene's glands are typically higher and located near the 1 to 2 o'clock range and the 10 to 11 o'clock range, if using the clock face to describe the vaginal vestibule. And a exam of the rectum, the bladder, and the urethra is important as well. Obviously, these can be directly evaluated. I don't necessarily, when checking for rectal tenderness, perform a rectal exam unless have other indicated reasons, i.e., I suspect endometriosis in the rectovaginal septum. Sometimes also when I'm looking, for hemorrhoids or any other direct rectal pathology. But when looking for rectal tenderness, you can palpate through the vagina, bladder tenderness, and urethral tenderness similarly. The adnexal exam, it's obviously bilateral in the pelvis. Oftentimes in the thin woman, the ovaries can be palpated, but oftentimes in postmenopausal women, the ovaries would be very small and difficult to palpate, especially if obesity is part of this picture. The uterine exam, I don't just examine the uterus for its mobility and its size, although these are important, but also it's very important to press in the retrocervical area, just below, just posterior to where the uterus is, where it joins into the where the cervix is, where it joins into the uterus and the uterosacral ligaments bilaterally. This is a common place for endometriosis. And one can often tell, especially if the uterus is palpated and frozen in this position, this can represent a frozen pelvis and severe endometriosis. Uterine tenderness can also tip us off to adenomyosis, which, if you remember, is when the endometrium grows within the muscular wall of the uterus, often creating a tender uterus, abnormal bleeding, and painful and irregular periods. The pelvic floor muscles are also an important part of that pelvic exam, and we discussed the location of those muscles, and this is often pressing, to fully evaluate these muscles, you want to press laterally at different varying depths into the vagina to palpate the pubococcygeus, iliococcygeus, and coccygeus, running from superficial to deep. And these will be pressing along the side, the vaginal sidewalls to the pelvic sidewall fully. The abdominal exam is also quite important. We're often taught as OBGYNs to do a bimanual exam, and in medical school, we're taught to do a bimanual exam, and that evaluates, you can better evaluate the contents of the pelvis. And while this is true, it's important when looking for pain or tenderness, doing a unimanual exam, so one hand, so that you can really isolate the adnexa, the uterus, for tenderness, and then separately evaluating the abdomen from above, and even performing a Carnet's exam where the patient flexes their abdominal wall musculature to see if that increases pain, because abdominal myofascial pain can often be a part of any pelvic pain syndrome. So moving on to abnormal uterine bleeding. So first of all, when you're diagnosing abnormal, we need to know what normal is. So the definitions are generally a cycle time of 28 to 35 days is normal. So essentially 7 days from the median. It should be 24 to 35 days. So essentially, 7 days post median is normal, and a lot less for the shortening of the period to 24 days. And this is considered ovulatory cycling, because essentially, if you're ovulating, if the ovaries are producing eggs, they're responding to the system correctly. The hormonal milieu is running appropriately, and menses reliably tends to occur 14 days post-ovulation. And this is the differentiation between developing oligomenorrhea, too much time between periods, polymenorrhea, periods too close together. The duration or heaviness of a period. A normal period is about 4.5 to 8 days. Although I will say in practice, I'm concentrating on exactly how long the period is less important than the volume. Our volume is typically defined as 5 and 80 milliliters, and this is typically something defined in studies. So when we're looking at increasing or lowering blood loss in a randomized controlled trials, these are the measures we use. But truly abnormal is more an opinion of the female. And abnormal is a volume that interferes with the woman's physical, social, emotional, or material quality of life. Oftentimes, we do define that as soaking a tampon more than once every 2 hours, and that can be a surrogate measurement of abnormal uterine bleeding. The causes of abnormal bleeding, the American College of OBGYN really uses a nomenclature called palm coin, and palm coin is helpful in determining these causes of abnormal uterine bleeding. And here's a slide that sort of demonstrates the palm coin. So we're looking at the polyp adenomyosis. Polyp is a just like you'd expect a colon polyp growing in the uterus. Adenomyosis, we discussed the endometrium growing within the muscle of the uterus. Leiomyoma, which is a fibroid, and these are benign growths of smooth muscle tumor. Malignancy and hyperplasia, of course, needs to be ruled out. Hyperplasia grouped with malignancy because it's a precancerous form of an endometrial malignancy. Coagulopathy. This can be either iatrogenically induced, which you can see later, meaning with anticoagulation, or this can have to do with an underlying coagulopathy, such as a von Willebrand's or disseminated endovascular coagulation as a more acute cause. Ovulatory dysfunction will cause abnormal uterine bleeding as well. We talked about the endometrium, sometimes a disordered endometrium, and this can happen as a result of contraception, birth control, or various other reasons, various other direct effects of hormones. We talked about iatrogenic causes, and then there's sort of a not otherwise catch-all, of course. This slide also goes into looking at the leiomyoma subclassification system, and essentially it's looking at, because location of fibroids are so important to the way the symptoms are developed, especially with regards to menorrhagia and fertility. There's a FIGO related subclassification and system, and you can see it's located here. Essentially, 0 is mostly intercavitary. Once you leave 2, it's outside of the cavity completely, and we look at sort of deeper into the endometrium, and these are ones that are extending all the way into the abdominal cavity, including the pedunculated, which looks like a polyp hanging off the bottom of the uterus, and a parasitic fiber, which is completely removed from the uterus, growing external to the uterine structure altogether. So fibroids, we talked about briefly, are benign growths of smooth muscle tumor. They're very common in women. Even 80% of women have been showed to have fibroids on autopsy. However, these were some very, very small. But many times these are asymptomatic, and indeed 15 to 20% of women with fibroids visualized on ultrasound will be asymptomatic. So that's not even including all of that 80% of women that have it, just the ones found on ultrasound. Only symptomatic fibroids need treatment. And the symptoms of fibroids are generally menorrhagia, so the heavy or irregular bleeding, pelvic pressure and pain. Typically, this pain isn't the severe type of pain that women can sometimes show with pelvic pain associated commonly with endometriosis or other causes, but mainly it's a dull, achy, heavy pain, sort of an extension of that pressure type pain. Or it's an affiliation with adenomyosis, which adenomyosis and fibroids have a common association. Also, a lot of these are related to the size of the fibroid and the pressure, or the location. So oftentimes urinary and bowel issues can develop just as related to a large fibroid pressing into the bowel or the bladder, causing urinary frequency, urgency, or even constipation and bloating related to the bowel. Fibroids have even been known to press into the ureters and hydronephrosis result. Now, surgical treatments. The type 0, 1, and 2, remember those are the ones that involve the endometrial cavity, can be removed hysteroscopically by putting a scope inside the vagina through the cervical canal into the uterus and removing the fibroid, usually using energy, or there are some dissectors that actually use mechanical blades and shave off the fibroids, can be removed this way as well. But if they're larger, even if they're 0, 1, and 2, they often have to be removed laparoscopically or by a laparotomy. All others can be removed laparoscopically. Again, there can be limitations due to size and location where laparotomy may be necessary. Otherwise, non-surgical treatments, there are medications. Leuprolide acetate or ulipristal is another medication, but not currently available in the United States, that can shrink fibroids. It typically shrinks about 15 to 40%. Uterine artery embolization can be used in certain situations. This is where pledgets are released into the uterine artery, and they essentially occlude blood flow as the capillaries shrink down. They physically block the blood flow into the fibroids. And again, they tend to shrink fibroids by 15 to 40%. Magnetic resonance guided focused ultrasound can be used. That's where a MRI machine is used, and focused ultrasound is used to ablate the fibroid. There are also some techniques used laparoscopically where the fibroid can be ablated with using small wires inserted into the fibroid, but we're seeing these a little less commonly, but they are worthy of mention. So moving on now to postmenopausal bleeding. I want to differentiate this from typical abnormal uterine bleeding because abnormal uterine bleeding, whereas it can be distressing and it can lead to severe anemia and be life-threatening in that way, and the premenopausal women is rarely cancerous, although that needs to be kept in the differential. Postmenopausal bleeding is a lot more concerning because any bleeding and spotting in the postmenopausal patient really needs a rapid examination to see needs to see a gynecologic or evaluation soon, because it's more likely to be cancerous or precancerous. There should be no active endometriosis in the postmenopausal patient. If there is, it could be a tumor creating hormones that are activating the uterus. Or it could be endometrial hyperplasia or a cancer in and of itself. Now, more commonly in the postmenopausal patient, where there is bleeding, it is a benign source, but this has to be differentiated. An atrophic endometrium can sometimes cause a minor amount of spotting. It's typically a very minor amount of isolated spotting, but sometimes this can cause a problem. This can cause bleeding that is asymptomatic but needs a workup. Now, anticoagulation can often be associated with this, and so sometimes we'll see atrophic endometrium with anticoagulation, and that will be a heavier bleeding, so it's important to keep that in mind. A uterine polyp can also cause this bleeding. Again, these are typically benign etiology, but there's certainly a higher risk of it being a cancer of containing a hyperplasia or a cancer, including these uterine polyps in postmenopausal women. especially because the uterine polyp is associated, its growth is associated with an excess of estrogen um, production, which is often related to obesity, but this excess estrogen production can also be associated with endometrial hyperplasias or endometrial cancers. Now, an endometrial hyperplasia and endometrial cancer are what we're looking for when we're evaluating postmenopausal bleeding. An ultrasound is typically the first bit of workup for this. An MRI will suffice if it was found incidentally, but an ultrasound will look to see if the endometrial thickness, the endometrial stripe we call it, is greater than 4 millimeters. If it is, we need to work it up, and we'll work it up with a biopsy. If the endometrial stripe is less than 4 millimeters, we can afford to be a little more cautious. But we do want to see if bleeding remains persistent. And if it does, a histological sampling is necessary. Endometrial biopsy can be done in the office, but in women who, for some reason, endometrial biopsy is not possible, either due to intolerance of the procedure or sometimes the stenotic cervix, which is not uncommon in the postmenopausal woman. Hysteroscopy improves diagnostics over D&C alone. Chronic abdominal and pelvic pain. 15 to 30% of patients who present, of women have chronic abdominal and pelvic pain, and 30% of women, of gynecologic visits can be due to chronic abdominal and pelvic pain. Because of this, it's very common. It's very commonly seen in the general surgeon's office, very commonly seen in the urologist's office. It's a very common shared pathology, and oftentimes, because these patients are bounced around quite a bit, I wanted to raise a little bit of our side of what we see in gynecology, and hopefully that will help in the general surgery workup as well. Now, when it's right upper quadrant, because I've been referred this sometimes, I generally think of that as you guys, but it can sometimes be an extension of the gynecologic pelvic pain etiology, and sometimes it is not a general surgery option or a general surgery evaluation. Looking at this lower abdominal and pelvic pain, sometimes it's GI in origin, especially if there's bowel dysfunction associated, constipation, diarrhea, pain with bowel movements, blood in the stool especially. I will recommend a referral to a general surgery or gastroenterology to work this up and help me with diagnostics. However, endometriosis can certainly be a cause, and bowel dysfunction can be associated. Common etiologies of pelvic pain. The most common we see are endometriosis, pelvic floor dysfunction, myofascial abdominal pain, pelvic pain, IBS and IBD, interstitial cystitis, and of course, essential sensitization syndrome, which is more associated with the upregulation of the way the nerve impulses are decoded in the brain, either a wider spread or an increased intensity. So just an example of how this is sort of what we sometimes see of the chronic pelvic pain patient, sort of bouncing around to here and there, and looking at sort of an example of one patient. An example of a patient who presents with chronic pelvic pain may be referred to interventional radiology, or to general surgery, to urology, gastroenterology, OB/GYN, colorectal, and may end up with pain management. But these arrows are certainly randomly placed and could end up as the final being any one of these. And you can see the red arrows are noting all the different things that sometimes we do: nerve blocks, colonoscopies, endoscopies, hysterectomies, oophorectomies, taking out the appendix, cystoscopies, ostomies, and even the use of opioids, which we all know is a large problem in our country today, especially in 2018, 2019. So how do I look at chronic pelvic pain? Well, generally look at a history. So looking at pain details, intensity, location, alleviating factors, initiating factors, radiation, the nature of the pain, all those things that we learned in medical school. I also always ask about the association with periods and cycles. This is associated with the urinary system, the bowel symptom, is associated with sex, and is there a psychiatric component to this as well? In the exam, we talked sort of about this evaluation. I don't want to go more in detail, but generally I want to rule out the uterus side next to the vaginal vestibule, Carnet's exam as part of the abdominal exam, looking at those pelvic floor muscles, also the pelvic girdle to see is there tenderness at the sacroiliac joint, is there tenderness at the pubic symphysis, is there leg length discrepancies, the coccyx tender, because oftentimes these can show a musculoskeletal origin as well. Looking at some of these pain phenotypes can be useful. Periods only, pain all the time, and sort of pain everywhere are three of the main sort of phenotypes that I see in my practice. Periods only oftentimes point to endometriosis, adenomyosis. Sometimes there can be outlet obstruction, especially if someone's had an endometrial ablative procedure. And these are very frequently gynecologic in origin, and if they're associated with periods only, they usually end up appropriately with us. But pain all the time can be a little bit broader, and then sometimes this is reactive to some other form of pain in the pelvis. So say there's IBS or irritable bowel disease, interstitial cystitis, the pelvic floor muscles will tense up in reaction. And this pain is a more of a, gosh, I have pain all the time. It's associated with movement, maybe after intercourse, it's a dull, achy, crampy pain. Sometimes it'll come out of nowhere and just bring me to my knees and be intensely painful. Radiates to the back, the legs, the vagina. And this is something that we commonly miss as gynecologists, as physicians in general. Now the pain everywhere. So this is, well, yeah, I'm here for my pelvic pain, but also I have migraines, fibromyalgia, shoulder pain, TMJ, a myriad of pain symptomatology, and sometimes these also manifest as dysautonomias, postural orthostatics syndrome, so POTS, faints and falls, issues that are sort of more associated with the autonomic nervous system, and these typically come from a centralized pain origin. They can originate in the dorsal spinal column. They're sort of shooting up those irregular, in more intense impulses than a stimulus would suggest. Similarly, you'll get crosstalk at the level of the spinal cord, and maybe a pain from endometriosis may end up feeling like pain in the rectum, feeling like IBS, feeling like interstitial cystitis, a pain in the bladder and associated with urinary frequency, urgency. And indeed, some people believe that IBS, IC are generally a centralized pain syndrome. Now, I want to address endometriosis as well, briefly, as we're wrapping up our talk about chronic pelvic pain, because the growth of endometrial tissue outside of the uterus. And there's three types. There's superficial, and these look like little blood blisters throughout the pelvis, sometimes purple dots, sometimes white gunpowder lesions, and we'll look at a few of those later. There can be cystic typically these are in the ovary, but don't have to be, and they have this dark brown sort of chocolate fluid that can come from them, and a deep infiltrating as well. Deep infiltrating endometriosis, typically sort of the consistency of a rubbery bouncy ball, and can look like just a thick fibrous adhesion. Endometriosis causes pain, subfertility, and organ dysfunction, and many of the patients end up presenting to the general surgeon who have bowel dysfunction. And it's important to recognize when you're looking at IBS, when you're looking at IBD, Those patients, oftentimes, all patients who have been long-term diagnosed with IBS, and they really had deep infiltrating endometriosis of the rectum. And a good way to recognize that is through a vaginal exam, palpating right behind the cervix, which is the most common place you'll see it involving the rectum as well. Patients with endometriosis involving bowel oftentimes have painful bowel movements, constipation as the two most common common symptoms associated. Usually, we can treat endometriosis via menstrual suppression, commonly, but we need to pay attention to their other chronic pain symptoms that may have resulted, or surgical interventions. When we look at chronic pelvic pain as a whole, and we look at those treatments, when our uterine adnexal hormonal is the primary treatment typically, and then surgical. Abdominal wall physical therapy, massage therapy, trigger point injections can be helpful. The pelvic floor, similarly, the pelvic floor physical therapy, which I want to emphasize because it has an impressive. You look at the bottom of the slide, it can be amazingly effective. 60 to 80% of women reported marked to complete improvement of pelvic pain with pelvic floor PT, which is probably better than any of the other treatments that we have. But also, going back up to looking at pelvic floor, we've used onabotulinum toxin A injections, Botox, to the pelvic floor to help relax those pelvic floor muscles, to go in conjunction, be an adjunct to pelvic floor PT when we're having trouble gaining ground in that way. In the pelvic girdle, injections, PT, chiropractic manipulations, and of course, it's important to treat anxiety, depression, and catastrophizing symptoms that go along with a lot of chronic pelvic pain symptoms. Education, counseling, medications, and lifestyle improvements can be helpful with this. The bottom line, treatments are often multifactorial, and syndromes do not occur in a vacuum. So when you treat one, look elsewhere for the others. And if you're unsure, send to a chronic pelvic pain specialist. Now I want to shift gears looking at gynecologic cancers, uterine, cervical, adnexal, and vulvar cancers. Uterine cancers, typically, the most common are endometrial and sarcomas. There can be secondary cancers such as from the ovary, but I'm going to concentrate mostly on endometrial and sarcomas. Endometrial cancer, we talked about sort of the two types. Type 1 are the endometrial cancers. These are endometrial in origin, strongly correlated with risk factors. Think about the risk factors for cholecystectomies: obesities, age, increasing age, especially over the age of 40, excessive estrogen intake, so hormone replacement therapy in postmenopausal women, estrogen-producing tumors, anything that activates the estrogen receptors, including tamoxifen. So women with breast cancer who have abnormal bleeding, it's important to keep this in mind as well. And then looking at genetics, the BRCA syndromes and Lynch syndromes oftentimes can be associated not only with ovarian cancers, but uterine cancers as well. These are often correlated, endometrial cancers, with abnormal uterine bleeding, menorrhagia, especially intermenstrual bleeding or irregular unpredictable periods. On imaging, you'll generally find a thickened endometrium. We discussed a greater than 4 millimeter endometrial stripe on ultrasound, postmenopausal women. But premenopausal women can have a thick endometrial stripe as well. If it's very thick, it should prompt a workup. Greater than typically 1.5 centimeters we use, but if greater than 40 and abnormal uterine bleeding, they really ought to have histologic sampling as well. Endometrial origin cancers, when we talk about worsening prognosis, a Pap serous type is a poor prognostic factor, as well as clear cell carcinoma. Endometrioid tends to be the best type prognosis. The bottom line is abnormal uterine bleeding in obese patients should be explored. Uterine sarcomas are much more rare. They're associated with abnormal uterine bleeding and enlarged uterus. The uterine sarcoma is usually a solid tumor mass, and risk factors are age and the presentation of fibroids on imaging. MRI imaging, lactate dehydrogenase Type 3 can help to predict a worrisome for a sarcoma, but it's very hard to diagnose by these factors. So mainly looking at severe anemia, symptomatic, unanticipated weight loss, and endometrial biopsy can be useful. Uterine sarcoma is most commonly found is the uterine leiomyosarcoma, a 1 to 250 or 1 to 2,500 risk factor. Prevalence is noted. It was previously thought to be much more rare, 1 in 10,000. But these can look a lot like fibroids and be difficult to differentiate. We talked about some of the increased risk factors of sarcomas, rapid growth of a fibroid, singular large fibroid, rapid weight loss or anemia. There's been a recent paradigm shift in the removal of the uterine fibroid. We used to morcellate fibroids, cut them up inside the abdominal cavity using power morcellators. Now we've largely moved away from that, and we've moved to a contained morcellation. There's still some argument whether with contained morcellation, we are fully augmenting the risk of spreading a potential leiomyosarcoma, but that risk-reward benefit is often discussed within the framework of the doing a larger incision in what the morbidity mortality is that compared to completing a laparoscopic procedure and morcellating a fibroid in a contained area. The bottom line, a large fibroid uterus can be removed minimally invasively, but really we should use a contained morcellation. So uterine cancers in general have a very good prognostic, especially if they're well localized. 81% of all comers have a 5-year survival, but you can see if it's localized just to the uterus, and the majority of these are. So if we catch them early, 94.9% of women have a great 5-year survival. Looking at cervical cancers, generally, you're going to see postcoital bleeding is how they present, intermenstrual bleeding, and oftentimes these are in relatively young women with poor access to healthcare, especially women who are not having PAP screening. The lesion on the cervix is a solid lesion, is always concerning. Oftentimes it could be a wart, but could be a cancer, so these should be biopsied if seen. And one thing not to be concerned about is a benign mucus-filled sort of normal contour cyst, which is a common finding in Nabothian cyst. But sometimes we'll get these lesions and need to evaluate to determine. If unsure, send for gynecologic evaluation. Cervical cancer screening and screening guidelines, as far as following the general rules to follow-up, can really lead to good prognosis in these patients. So here's a general way to look at cervical cancer screening. Generally, we're screening women between the age of 21 and 65, and regular screening intervals are generally every 3 years from age 21 to 65. However, in women 30 to 65, we can do PAP plus HPV, and then we use a 5-year screening interval. Now, if we find a small abnormalities, and these may be low-grade abnormalities or the ASCUS PAP, atypical squamous cells of undetermined significance, we'll repeat a PAP every year for 2 years until normal, then go back to regular screening. However, if it's higher risk, we'll do a colposcopy, is where we look very closely with a colposcope. We usually put acetic acid, and these light up, or Lugol solution, and they'll maintain sort of a lighter color, a yellow color, and we'll biopsy anything looking abnormal. If it remains high risk after the colposcopy, we usually recommend an excision, a loop electrosurgical excisional procedure, or a cone. And if we determine that there is a cancer, we'll look at hysterectomy, or if it's a higher stage, spread beyond the cervix is generally how we determine that. Radiation is the answer. Cervical cancer, as we discussed, when it's localized, is a really good 5-year survival rate. but not quite as good when it's spread more distant. It's a 66% versus the 81% when looking at endometrial cancers. So distant or regional spread has worsening prognosis. But as you can see, this is SEER data from 2015, and we can see that, 2016, but leading up to 2015 data, and you can see that when we're screening new cases, screening appropriately dropped from 11 per 100,000 to about 7 per 100,000. Pretty good drop, and we can see the death rate has dropped from just under 4 to just above 2 per 100,000 in the U.S. Looking at adnexal cancers, oftentimes we'll find incidental masses, and this is something we're sent cysts in gynecology all the time, and how we differentiate this. Oftentimes we need to tell women, benign cyst is present in a woman every month as part of the follicle. And sometimes we can find a more complex looking cyst with blood in it, which is a hemorrhagic corpus luteal cyst, or a corpus luteum. Once the egg is ovulated, and then bleeding that's incorporated into the cyst can actually make quite a large cyst that looks irregular. These are often less than 8 centimeters. They have a simple appearance, except the hemorrhagic cyst I was discussing. But complex typically has increased septations, papillations, growth of tissue, or increased blood flow. It also matters where we're seeing it, sort of where in the cycle, the age, and if premenopausal or postmenopausal. An evaluation should definitely be performed if it's in a frozen pelvis. If ultrasound, a CT is usually not sufficient. So if we're seeing a cyst on a CT, an ultrasound or MRI is indicated. Tumor markers can be an important part of this workup. CA125 is the most common. It's very, very commonly false positive in the premenopausal female, but in the postmenopausal female, if it's very elevated, it's more specific. Patients, then I want to kind of talk a little bit more about patients with cancer. So looking at how often we see adnexal masses in when these are referred actually to the gynecologic oncologist, you can see that very commonly we're seeing a lot of benign cysts, follicular cysts, endometriomas, leiomyomas, but we do see these borderline tumors, and then the lower show you the frequency of malignant tumors, which certainly happen but are less frequent. The lowest adnexal mass we discussed has a premenopausal CA125 less than 200, postmenopausal greater than 30, a stable appearance on serial imaging, and no internal Doppler flow on the ultrasound. They must look normal. Simple cyst masses that are less than 10 centimeters in a premenopausal patient can be reimaged after 6 to 8 weeks with or without hormonal suppression. High risk has an elevated CA125, complex findings. In the premenopausal woman, very elevated CA125. In any age of fixed pelvic mass associated with ascites or evidence of metastasis, obviously, plus or minus certainly a mass greater than 10 centimeters. The postmenopausal cyst, it's important there, when you do see a unilocular postmenopausal cyst, many of these do resolve at 6 weeks, but many can remain persistent. These can be followed yearly in a very simple, small, less than 10 centimeter cyst. But a complex cystic mass really needs to have really needs close follow-up. If less than 10 centimeters, if they're persistent or causing pain, should be surgically evaluated. If greater than 10 centimeters, no question, or looks complex and worrisome, should be surgically evaluated. Here's a management algorithm. I don't want to go through it too much for the interest of time, but we can see that if we're talking about moderate risk, sort of in the middle, if it's suspicious, on laparoscopy, we really need to do a definitive procedure to remove. But if there's a low risk of exam, we can repeat ultrasounds, follow ultrasounds, and CA-125s. Um, which one of these? So can you tell by looking at adnexal cancer which one of these are cancerous? The answer is none of them, actually. This is a uterine fibroid on the far left. On the top middle, again, is a uterine fibroid. The top right is a fibroma. I'm sorry, is a cystofibroadenoma. The bottom is bottom right is a fibroma, and that middle is a torused ovary. Now, the percent surviving adnexal cancers are less, 47% at 5 years, and this typically has to do with the fact that if you look at the bottom left hand, we typically find distant metastases in about 60% of patients on initial presentation, and so that's the explanation to the decreasing survival at 5 years. Vulvar cancers often present as itching, burning of the vulva, skin changes, thickening, or changes to the pigment, bleeding easily from a vulvar lesion. Your risk factors are an age greater than 65, smoking. HPV exposure is very, very commonly associated. And also issues with a weakened immune system. Is someone on say medication for autoimmune disease, or did they have a transplant and are on these medications that weaken the immune system? A history of lichen sclerosis or intraepithelial vulvar intraepithelial neoplasia disease is often common as well. How do you diagnose? It's biopsy. Should be pretty liberal with biopsy, and we are when we see these changes, especially associated with itching, burning. We treat this, determine the extent by imaging, sometimes CT looking for inguinal lymphadenopathy, surgical resection, including simpler radical vulvectomy with inguinal lymphadenectomy. So you can see we discover these early, looking at that lower left graph, and that's why the 5-year survival is relatively good. So now let's look at surgery in pregnant women. So remember, there are two patients, so the mother and the fetus. With maternal considerations, we look at their hormonal and their physiologic changes as in pregnancy, including hemodynamic changes. Talking about fetal considerations with the effect of medications, the anesthetics, as well as if radiation is required during surgery and in the preoperative workup. We also want to consider sort of what's the best timing in pregnancy as well. Certainly with maternal considerations, there is the mother's level of progesterone increases significantly, and this can lead to relaxation of sphincters throughout the body. This is well known, relaxing the rectal sphincter, the anal sphincter, as well as the urethral sphincter, leading to incontinence, but also looking at gastroesophageal reflux disease, which can lead to the heartburn common with pregnancy. Surgically, we need to consider that a pregnant woman is always treated as a full stomach by the anesthesiologist. And we'll also look at physiologic changes. Hemodynamic changes are common in pregnancy. You'll see blood volume increases. You can see sort of the middle of the slide looking at hematologic. The blood volume increases about 50%, and this results in the appearance of a physiologic anemia. Dropping the hemoglobin level about 2 points. Also looking at an increased cardiac output, heart rate increases, and you have a concurrent blood pressure decrease. All of these changes in association with more direct changes to factors in the blood leads to an increased risk of deep vein thrombosis, pulmonary embolism, and stroke associated with a prothrombotic state in the pregnant woman. And this needs to be considered in surgery in the pregnant woman. Moving on to sort of some of the pre-op workup, looking at the diagnostic imaging in pregnancy. This is all about risk reward. Here's an MRI, and you can see a fetus inside the womb. Looking at diagnostic imaging in pregnancy, there's two classes of radiation effects. There's deterministic, and this is where many cells and tissues are damaged. There's malformations as a result, intrauterine growth restriction, intellectual disabilities, a small microcephaly, as well as death can occur. This is usually not seen unless there's an exposure of greater than 10 rads of radiation. This is quite a few CT scans, quite a bit of radiation. Stochastic changes are really one cell etiology and may lead to carcinogenesis. Cancers in the fetus or in the placenta. It's not usually seen unless there's exposure of greater than 2 to 5 rads. So I'm looking at diagnostic imaging. You can see to the right, this is showing how much radiation is typically given based on the typical CT, abdominal CT, pelvic CT, and you can see how much gray or how much rad the fetus is exposed to. If you look at a less than 2 weeks gestation, a radiation of 5 to 10 rads is typically leads to an all or none situation. So either the patient is, or the fetus is born normally, or there's a miscarriage. Now, for every 100 rads of exposure, that's a lot of radiation. We're talking a loss of 25 IQ points. In greater than 20 rads to the young fetus, we're talking risk of malformation microcephaly. 6 rads, a risk of intellectual disability, especially between 2 and 8 weeks. Later on, you need greater than 25 rads to cause that intellectual disability between 16 and 25 weeks. And it takes a much smaller amount of radiation to incur a 2 times lifetime risk of leukemia in the child. There's also concern about effects of the fetal gonads and the thyroid with this lower dose imaging. Gadolinium is considered controversial in pregnancy, typically used with MRIs. There's limited data on this. However, we do know that it crosses the placenta and can be linked to rare skin conditions and increased risk of stillbirth. However, it can be used if necessary, especially if it's outside the first trimester. Nuclear imaging is mostly considered safe and it results in less than 5 rads of fetal exposure, although usually we're only considering nuclear imaging if it's really, really necessary. The exception to this is radioactive iodine for looking for thyroid disease. And we don't recommend iodine use, radioactive iodine use, as it can lead to decreased decreased use of the development of the fetal thyroidism and resulting cretinism. On diagnostic imaging, the bottom line is do not avoid giving tests to a pregnant woman unless there's a really, really good reason. Pregnant women can get sicker faster, especially with infective inflammatory etiologies like appendicitis and cholecystitis. Delaying diagnosis often confers an increased risk to mother and baby over and above the risk of the diagnostic imaging. So when considering more directly, when we're looking at non-OB surgery, it's actually not really rare. It occurs in 1% to 2% of pregnancies. Most commonly, it's the scope of the general surgeon with appendectomy and cholecystectomy. Orthopedic surgery is sort of the second most common, can result from trauma or other injuries. Past studies are not really a good indicator of risk. There's been studies that say we should avoid surgery, but this data is combined from a lot of different types of surgeries, and surgical patients are often compared to controls when they really should be controlled to patients who are pregnant who do not get surgery at the right time, who are not operated on. And of course, this has a lot of ethical issues um, um, related. So now looking at some of the anesthetic agents, virtually every drug has been demonstrated at some point under some circumstances, some dose to be teratogenic. So with that in mind, none of the commonly used anesthetic drugs are proven teratogens. Propofol, ketamine, etomidate, succinylcholine. Um, a choice of agent should really be based on standard anesthesia protocol. The placental transfer of neuromuscular blocking agents is minimal, and they are often used for fetal procedures without ill effects. So we're using them directly for fetal surgery and not finding ill effects. So it is safe for the fetus. There is a theoretical concern for nitric oxide on DNA production, myelin synthesis, but no actual damage has ever been shown. But if you're going to avoid any of these agents, these are probably the ones to avoid. A more critical concern in anesthetic agents is the rapid placental transfer of most of these agents that potentially can depress the fetus should emergent delivery become necessary. So when we're looking at emergent delivery, that's the time when we want to avoid these anesthetic agents, not when we're remote from delivery and not concerned of that as either a practicality, say the fetus is pre-viable, or a likelihood, say we just really don't expect any issues with the fetus. Regional anesthesia can be preferred when plausible in these situations. Reduces the risk of maternal aspiration and reduces fetal depression. This is why we typically operate under spinal or epidural anesthesia when we're doing a cesarean delivery. Recently, FDA warning came out suggesting surgery lasting more than 3 hours can be risky to the fetus, can affect fetal brain development. The science behind this was limited and really of poor quality. And really the fact that we're operating for greater than 3 hours connotes a serious maternal condition, which is probably more responsible to this. Based on this, the American College of OBGYN does not support this conclusion and recommends that if a surgery needs to be done, even if it's longer than 3 hours, it likely confers a greater benefit than a greater harm to the fetus. So surgical considerations. A common concern with surgery is early pregnancy loss in non-OB surgery. Reported risks are about 10.5%. However, risk of spontaneous abortion in the first trimester, so miscarriage in the first trimester in the general population, is 25 to 30%. Overall, 8 to 10% in once a pregnancy is recognized. So we're talking an increase from about 8 to 10% to 10.5%, which is a small increase. Historically, in these studies, there have been a lack of appropriate control groups and the heightened awareness of pregnancy in patients undergoing surgery. So this may be really artificially inflated, this number. Risks could be related to really the serious illness itself. So if someone has inflammation, generalized whole body inflammation, this really could be related, or sepsis from appendicitis or cholecystitis. This could really be related to the increased risk. Now looking at the comparison with preterm birth and non-OB delivery, the marker really should not be preterm labor specifically, because we definitely see this more frequently in appendicitis, cholecystitis, these issues when a patient does start to get sick. But risk is really reported to be about 8%, while overall risk of preterm birth in the general population is 10 to 12%. So in one study with patients with appendectomies, 22% delivered in the first week with no increased risk thereafter. So one would expect an increased risk of a potential life-threatening intra-abdominal infectious or inter-inflammatory process. So that's important to keep in mind, because we know that inflammatory processes, such as non-surgical issues like pyelonephritis, definitely increase the risk of preterm birth. Surgery should not be delayed in these situations because it's often curative and it may actually decrease the risk. Because we don't have those studies comparing women who don't undergo appendectomy. Usually, when we decide an appendectomy is needed, a delay only results in further inflammation, further infection. Now, we used to, back when I was in residency about 10 years ago or so, hypoxic fetal injury, we were looking out for that, but we were only really looking when a C-section was the way we could go, so when infants were viable. But now we're recognizing that there can be changes, hypotensive changes that can affect the fetus. And even though we can't deliver the fetus immediately in pre-viable situations, we can use anesthetic interventions that can increase the blood flow to the uterus. Essentially, we're using the fetal heart tone as a really early marker for hemodynamic changes, because uterine perfusion is usually the first to go. So when in some of the evidence to this is that in shock, the uterus is usually the last to be perfused. This is commonly associated with cardiothoracic or neurosurgery when they do end up with prolonged hypotensive episodes, even intentionally induced. So we really now recommend that we monitor at any gestational age for delivery, even if the patient is remote from delivery. So we can take those actions to increase the well-being of the fetus. In neurosurgery, we talked about that briefly. Common indications are brain tumors, intracranial hemorrhage, or traumatic brain injury, or spinal surgeries. Ironically, the prone position, we used to think that was worrisome for the fetus. It's actually probably better for uterine perfusion. However, it can be difficult to monitor. Osmotic diuretics are often used in these surgeries, and they are not contraindicated. However, and also hypothermia used also can actually improve neurological outcomes of the newborn. The greatest concern in neurosurgery is the hypotensive techniques, and this is a risk that sometimes cannot be mitigated. So sometimes before neurosurgical procedures, we'll consider delivery of the fetus prematurely, because that doesn't become an option to keep up that blood pressure, which may harm the fetus. In cardiovascular surgery, similarly, sometimes some of those hypotensive episodes, the reluctance to operate earlier because of pregnancy may contribute actually to a worse outcome, because sometimes patients are operated on when they are sickest. So surgery sometimes should be done sooner. Mainly this has to do with cardiopulmonary bypass, and fetal mortality rate of up to 30% has been reported. So we should try to lessen that possible exposure as much as possible and use high flow, high pressure techniques whenever possible. And then we should carefully monitor the fetus as well as the acid-base status. Laparoscopic abdominal surgery is probably what we see mostly in general surgery. In the non-pregnant patient, laparoscopic surgery has been shown to reduce operative time, post-op pain, length of stay, recovery time, and wound complications. And similarly, in the pregnant patient, in the past, there was a concern about CO2 inflation that could induce maternal hypercapnia, but this really hasn't borne out in the data. So we're less worried about this. The left subcostal entry is usually a good way, and Palmer's point is usually a good way to avoid the uterus. You can also use ultrasound guided entry to reduce uterine injury. Generally, although we're not worried about that hypercapnia, intra-abdominal pressures is best kept low to keep pulmonary venous return up. So we typically like to use a CO2 pressure of less than 10 to 15 millimeters of mercury. In conclusion, indications for surgery in pregnant patients is typically the same as non-pregnant patients. Fears leading to withholding surgery, indicated surgery for fear of teratogenesis and pregnancy loss or preterm birth are largely unfounded, and these fears may actually contribute to more adverse outcomes and may be a significant contributor to maternal and fetal morbidity and indeed mortality. So here's a couple things that you may see in surgery and what to do if you see these. So here's a benign follicular cyst. This comes every month, simple appearing. You can see a relatively normal appearing ovary and just sort of this little pink area where there's probably ovulation taking place. It's Similar appearing cyst in a postmenopausal patient, simple appearing on ultrasound. This can be followed yearly. This requires no treatment. Slightly enlarged ovary here, but relatively normal looking, is non-pathological. It can often be a hemorrhagic corpus luteal cyst. It occurs frequently as a result of a follicular cyst, can appear like an endometrioma. The treatment is non-surgical. If it's concerning, if there's a lot of pain associated, if there's more adhesions in the endometrial cavity, if there's endometriosis associated, we'll sometimes recommend fenestration. But you want to make sure you have good imaging before you're doing this to prevent spread of a malignant ovarian cancer, which could upstage. Otherwise, we'd follow these up in 6 to 8 weeks on ultrasound. This dark purple appearance is characteristic of a torsion and a torsed ovary. Most of the time, even a terrible looking ovary can be detorsed, an ovarian cystectomy can be performed, and the ovary can be saved. Prior risks are associated with hysterectomy. A cyst between 4 and 8 centimeters, smaller cysts tend to not twist, larger cysts tend to not be able to twist. Oftentimes an acute onset of pain in a white blood cell. Increase in white blood cells without evidence of left shift. Treatment, call a GYN for emergency treatment. These big, large but normal appearing ovaries are often polycystic ovarian syndrome. Oftentimes a metabolic syndrome is associated, meaning hyperlipidemia, increased blood sugars, pre-diabetic, and obesity. Oftentimes associated with oligomenorrhea or subfertility. Treatment is non-surgical, usually an estrogen-containing birth control or fertility treatments involving clomiphene citrate or letrozole. These are lesions of endometriosis. You can see these purple lesions. They can manifest with markedly different appearance, gunpowder lesions, purple, red, macular, papular, not popular as written. And the treatment is surgical excision or menstrual suppression. Please take pictures. These are really helpful to knowing whether or not we should go back in surgical or whether we should try to treat using hormones first. It's helpful to look behind the uterus, under the ovaries, at the diaphragm, and the appendix. This, with this chocolate brown substance coming out, is an endometrioma. Also called a chocolate cyst, ovarian cyst of endometriosis. It looks complex on imaging. It's often associated with adhesions in the pelvis, including the obliterated cul-de-sac. If it's causing pain or if it's greater than 8 centimeters, it requires cystectomy. If it's small and painless, you can just observe, and menstrual suppression can often help to prevent it from becoming larger and more painful. Please take pictures. Again, look behind the uterus, the ovaries, diaphragm, and the appendix. This is a look at the diaphragm, and these are endometriotic nodules on the diaphragm. The treatment for these are rare, but you can suspect them if there's cyclic right upper quadrant pain, sometimes associated with dyspnea and right shoulder pain, and sometimes this can be associated with intrapulmonary endometriosis. The treatment is excisional or menstrual suppression, and again, taking pictures is helpful everywhere where endometriosis can be. Appendiceal endometriosis is a strong correlation with stage 3 or 4 endometriosis. Of course, this is in your purview, but if you see endometriosis on the appendix and you remove it, it is super helpful if you can get those pictures elsewhere behind the uterus, under the ovaries, diaphragm, and appendix. These bright white pearly little nodules represent carcinomatosis of the ovary and ovarian cancer. And this is that stage 4 written, but also stage 3, diffusely spread. It is helpful. 1, to take pictures of these. Number 2, if you see somewhere where it can be easily biopsied, that can be helpful to establish as the carcinoma. Also to get pictures of the ovaries if possible, because the ovaries and fallopian tubes would be its most likely etiology. If those are normal, we might suspect more of a primary peritoneal cancer. Refer this patient to gynecology and intraoperative consultation with gynecology if possible. Here's a cyst of ovarian cancer. It does look highly abnormal. There's a lot of vasculature. You see this big dominant blood vessel here, but sometimes these can be hard to tell just by looking. Oftentimes, a hint is that they're bilateral. They're commonly diagnosed later, stage 3 or stage 4. Absolutely do not biopsy these. We don't want the liquid spreading with cancer cells and upstaging the cancer. So refer these to gynecology, interoperative with gynecology if possible. This generally requires full staging, total abdominal hysterectomy with a big open incision, bilateral salpingo-oophorectomy, both tubes and ovaries, pelvic and para-aortic lymphadenectomy and omentectomy, and pelvic washings. And complete resection of disease frequently involves bowel resections. If you see one of these sitting in the pelvis, here's a perforated IUD. Sometimes they're just sitting there, free floating. Sometimes they're adhesed to structures. These are radio opaque, but of course, if you're seeing it, you probably don't need X-ray to find it. Just go ahead and remove this from the abdomen, unless there's a severe risk of comorbidity by where it's adhesed, but it's worth removing these. Grab this by the end of the string. The upper arms, those thinner portions will just fold down and they can be removed through a 5mm trocar easily. Uterine fibroids, 80% of women have on autopsy, 15 to 20% of women with uterine fibroids on ultrasound, remember, develop are symptomatic. These generally look like big white balls with pink and red sort of small layer on top of it. These patients oftentimes have menorrhagia, pain, urinary symptoms, as we discussed before. The treatment's non-emergent. Refer to gynecology unless you see torsion of the fibroid, in which case it might be purple and causing a lot of pain. And then that is something easily removed and would be very helpful to be removed. Call intraoperative gyne consultation for that one. Now, I hope reviewing a little bit of the gynecologic considerations of general surgeons, as well as the surgery of in the obstetrical patient, has been helpful. The key takeaways I'd like you to take home from this talk are that reviewing pelvic anatomy helps with communicating pathology to gyne consultants. Abnormal uterine bleeding and chronic pelvic pain are important gynecologic pathologies to understand, so that we can adequately refer these back and forth to each other appropriately. Recognizing gynecologic changes is important so as not to delay the diagnosis of a potentially life-threatening disease. And in the pregnant surgical candidate, is important to know pitfalls, including knowing that improper inaction is really as dangerous as improper action. And then I hope the slides at the end can help sort of to identify some of the more commonly seen pathology that you're going to see while you're in for a general surgery type region. I want to give a special thanks to Dr. Chad Mitchell and Dr. Linda Chambliss for providing some of the content of and pictures, photographs in this slide. So thank you very much for your attention.